In today's class, we will be discussing about the effects of high altitude in respiratory system. We all know that as the altitude increases, there will be a fall in the atmospheric pressure. So in this diagram, the left hand side on the y-axis depicts the barometric pressure, that is 800, 600, 400, 200, and on the right hand side on the y-axis shows the inspired oxygen concentration. And the altitude is shown in meters as well as in feet. So we know that at around 760 millimeters of mercury, that is at this point, it is the sea level, atmospheric pressure at sea level, 760 millimeters of mercury, and as altitude increases, there is a fall in the barometric pressure, and also there is a fall in the inspired oxygen concentration. So this is what we understand from this diagram. So there is a alveolar gas equation. Alveolar gas equation, PaO2 equal to PiO2 minus PaCO2 by R plus F. F is a small correction factor. What is PaO2? That is the alveolar oxygen concentration. That is how much partial pressure of oxygen inside the alveoli of our lungs. So to calculate that, we have to find out the partial pressure of the inspired oxygen. That is the amount of partial pressure of the oxygen in the air we breathe around. So that is PiO2 minus, from that we have to subtract the PaCO2 by R factor. That is a carbon dioxide elimination factor. We have to subtract from the inspired oxygen concentration, and that will give us the alveolar partial pressure of oxygen in the alveoli. So so at a 760 millimeters, that is at sea level, there is a 47 is the, so at sea level if we calculate the PiO2, it is 760 minus 47 into 0.21. That is 0.21 is 21%. Is the fraction of oxygen in the, if you take 100 molecules of 100 molecules from the atmosphere, in that 21 molecules will be oxygen. That is the fraction of inspired oxygen is 21%. That is constant all throughout the atmosphere. So to find out the partial pressure of oxygen, we have to multiply the pressure into the fraction of inspired oxygen concentration. So the pressure will be 760 minus 47. 47 will be the partial pressure of water vapor. So that is also constant in all at all altitudes. So 760 minus 47 into 0.21, that will come out around 149 millimeters of mercury. So this is the alveolar gas equation. So at sea level, it is 149 millimeters of mercury. That is the partial pressure of inspired oxygen. So at a barometric pressure, that is half of sea level, that is at a 380 millimeters of mercury pressure, that will come at a 5,800 meters or 19,000 feet. So at an altitude of 5,800 meters, the barometric pressure will be only 380, that is 760 by 2. At that region, the partial pressure of inspired oxygen will be 380 minus 47 into 0.21, that will come out to be 70 millimeters of mercury. At Mount Everest, that is 48 meters, the partial pressure of inspired oxygen concentration is only 43 millimeters. And at an altitude of 19,200 meters, the partial pressure of inspired oxygen is 0. That is initially no pressure is exerted by the oxygen molecules, because at that high altitude there is no oxygen. Is there 0 millimeters of mercury. So that is how we calculate the PiO2. So as we move up, there is a fall. We have seen that the inspired oxygen concentration, partial pressure of inspired oxygen, PiO2 is coming down. That means there is a hypoxia as we go up. So this hypoxia will stimulate some changes in our respiratory system. So these changes can be acute as well as chronic changes. That is, short-term changes are also there and long-term changes are also there. So most important short-term change is hyperventilation, that is, we tend to breathe fast. So what is the importance of hyperventilation, that we will discuss. Also there will be increased RBC production, there will be increased RBC because there will be more hemoglobin. So hemoglobin is the main oxygen carrier in the blood, so there will be more oxygen carrying capacity will increase because of the increased hemoglobin. So that will occur in long term. So polycythemia is a chronic change. So compensatory changes can be acute and chronic. And also there are other changes. This we will discuss as we go further. So most important feature of acclimatization is hyperventilation. So how is hyperventilation helping? So we should know, we should be aware that hyperventilation and alveolar PCO2 are inversely related. Just keep that in mind. That is, alveolar PCO2 and alveolar ventilation are inversely related. So we will consider a scenario. That is, a normal person is going to Mount Everest with a alveolar PCO2. So our alveolar PCO2 is 40 millimeters of mercury. So if we are going to Mount Everest and our respiratory quotient is 1. So if we put these in the alveolar gas equation, the partial pressure of the oxygen in the alveoli will be 43. 43 is PiO2. That is, which we have already calculated in our previous slide. We calculated PiO2 to be 43. So 43 minus, as per this alveolar gas equation, this thing, that is PaO2 is equal to PiO2 minus PaCO2 by R. We are ignoring the F correction factor. So as per that, 43 minus 40 by 1, so we will see that the alveolar PO2 will be 3 millimeters of mercury. And so at the altitude equivalent to Mount Everest, 8848 meters, the alveolar PO2 is only 3 millimeters. In that we cannot survive. But we hyperventilate. So alveolar ventilation increases, means if we increase alveolar ventilation 5-fold, alveolar PCO2 come down 5-fold. So what happens is PCO2 becomes 40 by 5, only 8 millimeters. So with that 8 millimeter, if we calculate the alveolar PO2, we can get a better alveolar PO2. So that is 43 minus 8, that we get a 35 millimeters of mercury. So relative, that is 35 is far better than 3. So that is how hyperventilation helps in high altitude. Now we will see how this mechanism is happening, mechanism of hyperventilation. So in the high altitudes, there is a hypoxia. So this hypoxia will stimulate the chemoreceptors, peripheral chemoreceptors, and that will stimulate our respiratory center, and we will start to hyperventilate. So when we hyperventilate, there is a carbon dioxide washout, and because of the carbon dioxide washout, there will be respiratory alkalosis. So when there is a low PCO2 and a respiratory alkalosis, that will inhibit a hyperventilation. But we have to continue hyperventilating, then only we can survive, then only we can get a better alveolar PaO2 in the high altitudes. So what happens is that because of the alkalosis, there will be a change in the CSF pH also. So within day 1 itself, the CSF will pump out bicarbonate out and normalizes the pH. And also by day 2 and 3, there will be increased renal excretion of bicarbonate, and that will also normalize our pH. So again the hypoxia factor is persisting. So the hypoxia can again play its role in the peripheral chemoreceptors and again stimulate the hyperventilation. So even though the pH becomes normal even though the respiratory alkalosis is there and it can inhibit the hyperventilation, but because of the compensation, that is the CSF is pumping bicarb out and renal excretion of bicarbonate and bringing the pH back to normal and correcting the respiratory alkalosis, again the hypoxia will be able to stimulate the peripheral chemoreceptors and start on the hyperventilation. So the hyperventilation will continue. This is how hyperventilation is sustained in the high altitude. Also the sensitivity of carotid bodies to hypoxia increases. But there are certain things like some people are born in high altitudes, but so such people do not have this increased ventilatory response to hypoxia. So this is how the mechanism of hyperventilation occurs. Also there are other acute changes. So this hyperventilation is basically a acute change. So another important point, that is from an exam point of view, the oxygen dissociation curve, how it changes is, because of the initial hyperventilation and the hypocarbia and the respiratory alkalosis, initially there is a leftward shift of oxygen dissociation curve. So in high altitude, first it is the left shift of oxygen dissociation curve which is occurring. But later because of the hypocarbia and the persisting respiratory alkalosis, there will be followed by increased 2,3-DPG production also because of the hypoxia also. And increased 2,3-DPG production will eventually result in a rightward shift of oxygen dissociation curve. So the question answer is, initially in high altitude there is left shift and followed by right shift of oxygen dissociation curve. So other acute changes which occur are an acute hypoxic pulmonary vasoconstriction. This is a compensatory mechanism to prevent ventilation perfusion mismatch, that is to reduce the shunt. So these alveoli are not properly getting enough oxygen, so the blood is like impure blood is going directly from right to left, so there is a increased shunt It is just like shunt. So what happens is we have to reduce the pulmonary blood flow to reduce the shunt fraction. So in that way there will be hypoxic. It is actually hypoxic pulmonary vasoconstriction is not having much benefit. More than that, it is doing more harm. That is, it is increasing the strain because it is increasing the pulmonary artery pressure without increasing the left-sided pressures. It is only increasing the right-sided pressures, so it will increase the right heart strain. And it's actually an acute response. Finally, on chronic stay in high altitude, there will be followed by what happens is there will be pulmonary artery pressure, there will be increase in the work on the right heart, there will be right ventricular hypertrophy, there will be pulmonary hypertension, there will be pulmonary edema happening because of this hypoxic pulmonary vasoconstriction. But in all these cases, the pulmonary venous pressures will be normal. So these are the acute changes which occur, compensatory changes. And in this, only hyperventilation is beneficial and hypoxic pulmonary vasoconstriction is not at all beneficial. It is doing more harm. Other chronic response which occur is polycythemia. So polycythemia is because of the hypoxia, there is increased erythropoietin production from kidney by day 2 and 3, and that will stimulate the bone marrow for increased RBC production. So there will be increased RBC concentration of the blood, and there will be increase in the hemoglobin concentration and increased oxygen carrying capacity. So even though the partial pressure of oxygen and the oxygen saturation are reduced, oxygen concentration of the arterial blood will be normal or even above normal because of the increased hemoglobin. So more hemoglobin will, whatever hemoglobin is there, that will bind all the oxygen which is available. So it is effective utilization of the available oxygen will take place because of the increased hemoglobin concentration. So such people residing in high altitude will have hemoglobin of around 19.8 and arterial oxygen concentration of around 22.4 per 100 ml. But the adverse effect is that there will be increase in blood viscosity because of the increased red cell mass, and there can be adverse effects related to the increased blood viscosity. So how this polycythemia helps, we can understand from this diagram. So from this oxygen cascade, we can see that the inspired air concentration is high in sea level, but at 4,600 meters it's low, and it is coming down again, and finally it is a mixed venous blood oxygen concentration. So we can see that the mixed venous blood oxygen concentration is almost similar in a person at sea level and also at a person at a height of 4,600 meters. And this difference is only 7 millimeters. This difference is low because of the increased hemoglobin and increased oxygen carrying capacity of the hemoglobin. So that is one which makes the difference very narrow. And also we should understand that hematocrit increases even before the this erythropoietin production and all takes place. That hematocrit increases because of the decrease in the plasma volume. So there are other changes which occurs. That is also there will be an increase in the number of capillaries per unit volume in peripheral tissues will be there. And also there will be changes occurring in oxidative enzyme within the cells. Breathing capacity increases to about 200 liters per minute. So these are